Hello, everyone. My name is Rebecca Rohal. I want to welcome you and thank you in advance for joining me. I look forward to sharing my DNP project, Anesthesia Provider Awareness of Sugammadex Hypersensitivity, patients outside the SugammaBOX. At this time, if you have not yet completed the pre-survey, please pause this presentation to complete it before we move forward. To complete the survey, please scan the QR code on the screen with your cell phone or click the link titled Pre-Presentation Survey found in the email sent to you. The objective of this presentation is to increase anesthesia provider awareness of Sugammadex perioperative hypersensitivity. Participants will increase or reinforce their current knowledge that surrounds the clinical assessment and management should a reaction present during clinical practice. By the conclusion of this presentation, participants will understand that although Sugammadex is a very effective immunosteroid neuromuscular blocking reversal agent, timely recognition of a potential Sugammadex-induced reaction is crucial for timely corrective treatment and optimal patient outcomes. The agenda for this presentation includes a review of perioperative hypersensitivity, or POH, Sugammadex, the mechanism by which Sugammadex may cause a POH reaction, clinical presentation and management, and lastly, I will discuss my literature review findings of the association between Sugammadex and POH. Perioperative hypersensitivity, POH, is an unpredictable reaction linked to common medications used by anesthesia providers. The overall incidence of POH occurs during 1 in 355 to 1 in 18,600 procedures, quite variable. As this is likely not a surprise to you, anesthesia providers commonly associate POH with a group of medications called neuromuscular blocking agents, which are administered to obtain muscle relaxation to optimize intubation as well as surgical conditions. Less commonly associated with POH is Sugammadex. Sugammadex is the first selective relaxing binding agent, SRBA, used as a neuromuscular blocking reversal agent. One study by Kim et al. 2019 shows that Sugammadex POH may be as high as neuromuscular blocking agent rocuronium-induced POH. The severity of POH ranges from mild to severe. Mild reactions tend to present with more generalized cutaneous mucosal signs, including urticaria, erythema, and angioedema. Moderate reactions commonly present with the same cutaneous mucosal signs with cardiovascular and respiratory involvement. This may present as hypotension, tachycardia, or bronchial irritation that may present as a cough or decreased ventilator compliance. Worth noting is that when a mild or moderate reaction does go unrecognized or undocumented, subsequent exposure may result in more severe reaction. Severe POH reactions are defined as perioperative anaphylaxis, or POA. POA has the highest rate of mortality at 1.4 to 4.8% when compared to other anaphylactic reaction etiologies. POA is life-threatening with an occurrence of 1 in 1,250 to 1 in 2,000 procedures. Typical presentation includes cardiovascular collapse, bradycardia or tachycardia, hypotension, cardiac arrhythmias, bronchospasm, and possible death. Regardless of whether POH is mild or severe, the anesthetized patient cannot communicate symptoms that may otherwise indicate the anesthesia provider's signs and symptoms of POH. Symptoms may be missed and instead attributed to the effects of anesthesia, airway manipulation, or physically obscured by surgical drapes. Moving forward in this presentation, POH will encompass the spectrum of mild to severe reactions unless otherwise specified. Sugammadex is approved in both adult and pediatric patients who are over the age of 2 years old undergoing surgery. Dosing of Sugammadex is based on the actual body weight, train of 4, and/or post-tetonic count evaluation. Administration guidelines state that Sugammadex should be administered by bolus dose by IV route over 10 seconds. More detailed information in regards to administration and FDA updates can be found on the Bridian website updated in 2024 and the FDA Access, where you can find the most recent package insert updated in 2022. Sugammadex was approved for administration by the European Union in 2008. Due to anaphylactic reaction-related concerns, the U.S. Food and Drug Administration delayed approval of administration until 2015. In 2021, the FDA expanded approval to pediatric patients who are over the age of 2 years old. Structurally, Sugammadex is a modified gamma-cyclodextrin. Cyclodextrins are a family of sugar compounds chemically bound by glucose units that form a ring. Derived from plant starches, aside from pharmaceuticals, cyclodextrins are used in food, agriculture, and environmental engineering. Typically, cyclodextrins contain 6 to 8 glucose units. For example, an alpha cyclodextrin has 6 units, a beta cyclodextrin has 7 units, As illustrated in Figure 1A, gamma-cyclodextrin Sugammadex has 8 units and forms a 3-dimensional ring structure with a hydrophobic core and hydrophilic outer surface. As illustrated in Figure 1B, you can see how the charged tails attract positively charged rocuronium or becuronium into the central core of Sugammadex. Thus, the hydrophobic core of Sugammadex encapsulates aminosteroid neuromuscular blocking agents, which are ultimately excreted unchanged in the urine. Allergic POH involves patients' cellular and humoral immune responses or the direct activation of mast cells. Although pathomechanisms of various hypersensitivity pathways are beyond the scope of this presentation, the chemical structure of an allergen and induction of sensitization plays an important role in how Sugammadex can provoke a hypersensitivity response. Mast cells are known for their mechanism of action to produce IgE-mediated allergic reactions via Fc receptors, which are proteins that bind to infectious cells or pathogens. In the phenomenon of sensitization, exposure to an allergen, such as Sugammadex, can lead to the development of specific IgE high-affinity Fc receptor complexes that attach to the outer membrane of mast cells. The primary role of these receptors is to then trigger phagocytic or cytotoxic cells to destroy invading cells by antibody-mediated phagocytosis or antibody-dependent cell-mediated cytotoxicity. Therefore, upon second exposure to the antigen, such as Sugammadex, the permanent IgE Fc complexes are created, and subsequent mast cell activation with the release of chemical mediators such as histamine and tryptase is established, and you have the clinical presentation of POH. On that note, it is essential to highlight the molecular vulnerability of Sugammadex as a cyclodextrin, because according to Gonzalez et al. 2021 and Kajizuk and Knapp 2021, over 60% of POH cases are IgE-mediated. Iwasaki and colleagues 2017 found many patients who have experienced Sugammadex POH had no prior exposure to Sugammadex, which may be explained by cross-exposure due to cyclodextrin-containing compounds. As a novel medication, it can be postulated that as administration increases, POH will increase too. Estimates of actual Sugammadex administration and incidence of hypersensitivity is variable across the literature. The Allergen Survey 2018 estimates that there are 64,121 exposures to Sugammadex yearly. According to Ju et al. 2022, between 2014 and 2019, the sales volume of Sugammadex increased by 618%, from just under 60,000 to over 400,000 vials, which simultaneously increases the potential for cross-exposure of the various cyclodextrin compounds. As Sugammadex becomes formulary at more and more hospitals, these numbers will inevitably increase. The Ring and Mesmer scale 1977 is still the most commonly used assessment tool to evaluate the clinical course of hypersensitivity reactions, as illustrated in Table 1. As I mentioned earlier in the presentation, verbiage of severe POH and POA or anaphylaxis overlap in the literature. POA includes the onset of generalized cutaneous mucosal symptoms that are accompanied by more severe symptoms. The Sampson criteria is an evidence-based assessment tool that can help anesthesia providers distinguish symptoms that are indicative of anaphylaxis, as illustrated in Table 2. For example, a decrease in blood pressure greater than 30% from the patient's baseline. Of course, anesthesia in itself leads to decrease in blood pressure. This tool is to serve as an adjunct that you can use with your clinical judgment and the overall patient picture. When early assessment of Sugammadex POH takes place, management surrounds the preservation of the patient's airway, breathing, circulation, diagnostics, and prevention of reoccurrence. In the case of Sugammadex POH, the airway should be assessed and secured at the anesthesia provider's discretion. At a minimum, oxygen by face mask and continuous assessment for delayed onset of angioedema, respiratory involvement, or loss of consciousness is recommended. Severity assessment tools, as discussed, can help anticipate the requirement for intubation. Often, Sugammadex POH reactions take place post-extubation or en route to the PACU. In the review by Arslan et al. 2021, 18% of Sugammadex POH cases did require reintubation. Rapid reversal of bronchial smooth muscle by Sugammadex has been associated with bronchospasm. Standard recommendations to relieve bronchospasm are discussed across the literature. Epinephrine administration is an effective measure to relieve POH-induced bronchoconstriction. With the ability to ventilate, treatment with short-acting bronchodilators and sevoflurane is recommended. Recommendations for refractory bronchoconstriction and the inability to ventilate include racemic epinephrine, ketamine, or magnesium. Standard of care also includes the administration of IV glucocorticoids, but note a delayed onset of 4 to 6 hours. Volume repletion is also centered on the severity of the POH reaction. At minimum, a patent, fast-running, large-bore IV access should be established and or maintained contralateral to the non-invasive blood pressure cuff. In severe POH, peripheral vasodilation and capillary leakage require large volumes of IV crystalloid and colloid as first and second line replenishment, respectively. Literature recommendations encourage volume replacement between 20 and 30 mLs per kilogram until hemodynamic stability is restored. And this can be defined as a minimum of 60 millimeters of mercury or above a level that maintains coronary and cerebral perfusion and cardiac output. Epinephrine remains the first-line treatment for POH, but the differences in dose recommendations can be confusing in an acute and emergent POH reaction. The World Allergy Organization recommends an IM injection of epinephrine in the mid-anterior lateral thigh when anaphylaxis is diagnosed. Dose recommendations are 0.01 milligrams per kilogram of 1 in 1,000 solution with a max of 0.5 and 0.3 milligrams in adults and children, respectively. Keep in mind that POH takes place in the operating room environment, and therefore epinephrine by the IV route is typically the first route of administration that we will take, and of course recommended to correct cardiovascular disturbances that typically present with severe POH. Arslan et al. 2021 found that 25% of anaphylaxis cases that presented with an indication for epinephrine did not receive epinephrine. Dosing of epinephrine can be subjective and largely based on response. The literature recommendations for grade 2 reactions are between 10 and 20 mics to 10 and 50 mics of epinephrine. For grade 3 reactions, recommendations for an initial bolus dose of epinephrine start at 50 micrograms, increase to 100 micrograms, followed by 200 micrograms if there is an inadequate response. Other recommendations say to start at 100 to 200 micrograms, administer every 1 to 2 minutes, and then after the third bolus dose, start a drip at 0.05 mics per kg per minute with titration rates of up to 0.1 to 0.5 mics per kg per minute. Grade 3 reactions refractory to epinephrine can be treated with vasopressin or methylene blue, with recommendations of doses to be 1.5 to 3 milligrams per kilogram and administered over 30 minutes. Grade 4 anaphylactic reactions commonly present as pulseless electrical activity. Recommendations for this scenario include and require CPR and standard advanced cardiac life support, which includes the administration of 1 milligram of epinephrine every 3 to 5 minutes until there is a return of spontaneous circulation. Due to the risk of cardiovascular arrest on presentation of cardiovascular collapse with paradoxical bradycardia, atropine should be avoided. Recommendations from the 6th National Audit Project recommend that CPR should be started with refractory systolic blood pressure less than 50 millimeters of mercury, even without cardiac arrest. One of the limitations to the diagnoses of Sugammadex POH is the lack thereof. Serum tryptase is a serum marker that is specific for mast cell activation and can be used specifically to diagnose Sugammadex POH. Serum tryptase should be drawn within 30 minutes to 2 hours post-symptom onset. In addition, a basal serum tryptase level should be collected at least 24 hours after symptoms resolve and in conjunction with a complete allergy investigation. An algorithm of peak serum tryptase is used to compare peak serum tryptase levels to serum basal levels to determine the initial diagnoses. To prevent a potentially life-threatening re-exposure, a firm diagnosis is crucial. According to one report by Mertz et al. 2016, only 50 to 60% of anesthetic POH was diagnosed by conventional skin prick tests or alternative in vitro tests. Drug provocation, however, is the gold standard of drug allergy testing because it can confirm or exclude Sugammadex regardless of the underlying mechanism. A positive provocation test will result when hypersensitivity symptoms from the initial POH are reproduced. For example, in a case that presented with cardiovascular or respiratory compromise, a low dose may present with cutaneous mucosal symptoms. In my literature review, I found growing evidence to support a rare but serious association between Sugammadex and POH reactions. Unfortunately, there are limited randomized control trials to evaluate Sugammadex-induced hypersensitivity, specifically Sugammadex POH reactions that take place during the perioperative process. For example, only 4 randomized control trials have been conducted to evaluate Sugammadex-induced hypersensitivity. Across the randomized control trials by DeCam et al. 2018, Min et al. 2018, Peters et al. 2010, and Voss et al. 2020, findings reveal that 1 in 20 patients will experience a mild or moderate hypersensitivity reaction, and 1 in 50 patients will experience a dose-dependent anaphylaxis. To date, a growing number of case reports and retrospective studies report the presentation and likely association of POH and Sugammadex. This creates significant ambiguity between reported versus the actual incidence of Sugammadex POH. Common themes associated with Sugammadex POH include evidence of underreporting, dose-dependent reactions, bradycardia and/or cardiac arrest, and a potential genetic predisposition. A recent meta-analysis evaluating Sugammadex POH warns that anesthesia providers should be aware that Sugammadex POH reactions, including anaphylaxis, are underreported in the literature. Arslan et al. 2021 identified 33 cases of Sugammadex-induced anaphylaxis within 23 records. Findings revealed that most cases revealed grade 3 or 4 anaphylaxis and required reintubation, and that adult women with an average age of 43 years old were most affected. The review included 6 pediatric cases and 10 different surgical specialties, with the most common to include ENT, general, and orthopedic surgery. In this review, 5 of the cases were due to the Sugammadex rocuronium complex, in which 3 of the 5 tested negative for Sugammadex alone. The most common symptom that presented was hypotension, and the least common was bradycardia. In a subsequent review, Zek et al. 2022 found within 23 cases, the incidence of severe Sugammadex-induced POH was between 0.02 and 0.04%. Both Arslan et al. 2021 and Zek et al. 2022 confirmed that the onset of Sugammadex POH reaction typically occurs within 5 minutes, but can range anywhere from 1 to 8 minutes. According to the Sugammadex package insert, the rate of anaphylaxis is 0.33%, and hypersensitivity reactions are more often associated with increased doses. This incidence was based on a single study on 299 healthy non-anesthetized participants, which did reveal 31 cases of hypersensitivity and 1 case of dose-dependent anaphylaxis. A subsequent RCT conducted by Merck produced similar findings of overall hypersensitivity and anaphylaxis in healthy participants to be 25 and 1 respectively. This study highlighted that overall hypersensitivity incidence was non-dose dependent, while anaphylaxis was more likely with the administration of higher doses. In contrast, DeCam et al. 2018 found Sugammadex POH to be dose dependent. Although there is not a RCT to evaluate Sugammadex administration over 4 milligrams per kilogram in the pediatric patient population, one RCT illustrated that adverse events as defined by the authors as bradycardia, pain, nausea, vomiting, pyrexia, and increased temperature to increase after 4 milligrams per kilogram Sugammadex when compared to 2 milligrams per kilogram of Sugammadex. Lastly, in a systematic review by Zek et al. 2022, including data extraction from 25 individual cases of Sugammadex-induced anaphylaxis, findings did not indicate a dose-dependent relationship, and of the cases who experienced POH, doses ranged from 0.7 to 4 milligrams per kilogram. From 2014 to December 31, 2020, a total of 282 cases of major cardiac events following the administration of Sugammadex were reported to the FDA Adverse Event Reporting System database. Major cardiac events were defined as bradycardia, cardiac arrest, cardiorespiratory arrest, hypotension, and decreased oxygen saturation. Al-Subini et al. 2020 conducted a prospective observational study that reported 18 cases of bradycardia with a median onset within 2 minutes. This study did include a higher proportion of pediatric patients with a history of congenital heart disease. In the pediatric randomized controlled trial by Voss et al. 2020, there were 10 and 39 cases of bradycardia that required emergent intervention after 2 and 4 milligrams per kilogram of Sugammadex administration, respectively. Despite the several case reports of bradycardia and cardiac arrest following the administration of Sugammadex, the explanation remains unclear. With no clear evidence across the literature that Sugammadex has direct cardiac side effects, it is postulated that the Sugammadex bradycardia phenomenon may be the result of a rare type of hypersensitivity reaction. For example, in POH, mast cell activation is responsible for the release of numerous inflammatory mediators that can present as bradycardia and hemodynamic instability. In result, systemic vasodilation and decreased venous return, secondary to increased vascular permeability, can lead to decreased cardiac output, which present as bradycardia and/or cardiac arrest. A second explanation is Kuhn's syndrome, which involves an interaction between an allergic reaction and the cardiovascular system. With an incidence of 3.4% of allergy patients, Kuhn's syndrome presents with cardiovascular symptoms that are secondary to the release of inflammatory mediators due to coronary artery vasospasm or plaque erosion and rupture. There are several case reports across the literature that point to Kuhn's syndrome as a potential cause for bradycardia or cardiac arrest due to coronary vasospasm after Sugammadex administration. Kuhn's syndrome is a possibility when patients present with an acute coronary event and no epicardial coronary artery stenosis is found on cardiac cath. The combination of serum tryptase and cardiac enzymes, specifically CK and CKMB, and cardiac troponins, support the diagnoses of Kuhn's syndrome. On EKG, ST elevation in the anterior and inferior leads is common due to vasospasm of the right coronary artery, which is most commonly affected. Echo, coronary angio, cardiac SPECT, and MRI can also be used in a differential. Arslan et al. 2021 reports over 60% of the identified Sugammadex POH cases to have occurred in Japan. This suggests the possibility of a possible genetic predisposition in that region. In the systematic review performed by Zik et al. 2022, 44% of Sugammadex-induced anaphylaxis cases were also based in Japanese hospitals. To compare the notable region-specific increase, Takazawa et al. 2021 and Orihara et al. 2020 report that the Japanese Sugammadex-induced anaphylaxis incidence to be around 0.02%. Meanwhile, an American retrospective study conducted by Burbridge 2021 estimates that incidence to be far less, 2 in 23,446. These statistics highlight great variability in what the actual incidence might be. The notable region-specific increase may also be attributed to a greater overall exposure to Sugammadex linked to earlier approval rates in that region, anesthesia practice norms, or cross-reactivity with preservatives in Japan. Several gaps exist across the literature due to the novel nature of Sugammadex, with great variability likely due to a lack of laboratory confirmation of Sugammadex-specific POH. Further research is needed to conduct more comprehensive studies that incorporate drug provocation to determine POH incidence. Additional research to assess provider recognition of POH, voluntary reporting, is also indicated to increase anesthesia provider awareness. Lastly, randomized control trials have only evaluated Sugammadex administration as an IV bolus dose administered over 10 seconds. More comprehensive studies that evaluate the timing and speed of administration in association with POH are also required. Here is my reference page. This concludes my presentation. At this time, please scan the QRS code with your cell phone or click on the link titled Post-Presentation Survey in the email you received. At the end of the survey, you will have a chance to obtain your $5 Starbucks gift card. Thank you for joining me.